Hello, friends, and welcome to episode 1238 of the Juicebox Podcast. Dr. Blevins is back today to expand on his GLP conversation from a few weeks ago. Today, we're going to be taking listener questions. Dr. Blevins is going to do his best to answer them. Nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before making any changes to your healthcare plan. Hey, if you have type 1 diabetes or are the caregiver of someone with type 1 and a U.S. resident, I need you to go to t1dexchange.org/juicebox and complete that survey. That survey helps the T1D Exchange to move type 1 diabetes research forward. t1dexchange.org/juicebox. If you've ever wanted to help, this is your chance. It will only take you about 10 minutes. When you place your first order for AG1 with my link, you'll get 5 free travel packs and a free year's supply of vitamin D. drinkag1.com/juicebox. I know that Facebook has a bad reputation, but please give the private Facebook group for the Juicebox Podcast a healthy once-over. Juicebox Podcast, Type 1 Diabetes. Today's episode of the Juicebox Podcast is sponsored by the Contour NextGen blood glucose meter. This is the meter that my daughter has on her person right now. It is incredibly accurate and waiting for you at contournext.com/juicebox. Today's episode is sponsored by Medtronic Diabetes, a company that's bringing people together to redefine what it means to live with diabetes. Later in this episode, I'll be speaking with Jalen. He was diagnosed with type 1 diabetes at 14. He's 29 now. He's going to tell you a little bit about his story. To hear more stories with Medtronic champions, go to medtronicdiabetes.com/juicebox or search the hashtag Medtronic champion on your favorite social media platform. All right, everybody. So Dr. Tom Blevins is back. We're going to do another episode around GLP medications. If you have not heard his first one, it's episode 1212. But today we're going to do all questions from the audience. So Tom, welcome back.
Scott, good to be here.
Good. I'm glad you were so good the first time. I'm excited for you to be back again. I'm just going to jump right into questions that came from the audience about GLP meds. I don't know that we're going to get through all of them, but let's do it.
All right.
So I'm going to start right at the top. My 7-year-old is very overweight. Doctor suggested possibly giving her one to help her lose weight over the summer. Is this safe for young children and effective? She's type 1. She lost 40 pounds before diagnosis and has gained 60 back. Cannot stop eating.
Yeah, that is a tough problem that she's lost because of the high blood sugar to begin with, and now she's gained back everything and then some. And she's hungry, and hunger is a tough deal. It's possible certainly that insulin induces some hunger, promotes it. And she's overweight now. We don't know the details, but here comes the summer. You want her to lose weight, and the question is about GLP-1s, the glucagon-like peptide-1 meds. And I'll tell you, it's important to look at what's been done in terms of studies and all that. When I answer this question, and the answer is there is no medicine approved at this point for a 7-year-old, and for any purpose, for diabetes or for weight loss, and there's no GLP-1 approved. The approvals are the one called Saxenda, which is liraglutide, the once-a-day injection. That one is approved for weight loss in the pediatric population down to age 12. Mm-hmm. So that's not going to go. And the bottom line when it comes to approvals here is that we just don't have data, so we don't know. The person who asked the question could talk to their doctor and ask about that. That's certainly something they can talk about, but I would be reluctant to go that direction. It's a really good thought, and you'd love to get her to lose weight, that's for sure. But anyway, I'd be very, very cautious about that. Talk to a doctor and work maybe with, this might be a time, everyone that's listening probably has talked to a dietitian before. Dietitians can be very effective. So it might be a good time to talk to a person like a dietitian to talk about the eating.
Mm-hmm. Is there a possibility? So first of all, this suggestion's coming from their physician. So I don't know. I can't make you guess about this, but is there a world where you would ever look at a 7-year-old in a similar situation and have this thought, or you wouldn't go this way?
Full disclosure, I see mainly adults, and I don't really see 7-year-olds, so I couldn't answer that about a 7-year-old. But, this is a place where the doctors can use medicines, as you know, off-label, and they can look at the indication, and they could use a medicine that doesn't kind of fit the indication. It's a clinical judgment call. We don't know about safety for young kids, and would it be less effective, more effective? We don't know. I suspect it would work the way it does for older children. So the answer is we just don't have much data there.
Okay. Let me jump to the next question. I'm going to jump around a little bit on this list, but just a very simple question. Does a GLP medication cause muscle loss? So if you're paying attention in this space, when GLPs became kind of in the limelight maybe 2 years ago, I think Dr. Peter Attia pretty famously said that his practice took a look and said that people were losing muscle. And I think that became one of the concerns out in the media and everything. Now, I've been on it for 13 months now. I don't feel like I've lost muscle, but as a matter of fact, I feel stronger now than I did before. But does it cause muscle loss, or is that just part of losing weight, or what are we seeing? ContourNext.com/juicebox. That's the link you'll use to find out more about the Contour NextGen blood glucose meter. When you get there, there's a little bit at the top. You can click right on blood glucose monitoring. I'll do it with you. Go to meters, click on any of the meters. I'll click on the NextGen, and you're going to get more information. It's easy to use and highly accurate. SmartLight provides a simple understanding of your blood glucose levels. And of course, with second chance sampling technology, you can save money with fewer wasted test strips. As if all of that wasn't enough, the Contour NextGen also has a compatible app for an easy way to share and see your blood glucose results. ContourNext.com/juicebox. And if you scroll down at that link, you're going to see things like a buy now button. You could register your meter after you purchase it. Or what is this? Download a coupon. Oh, receive a free Contour NextGen blood glucose meter. Do tell. ContourNext.com/juicebox. Head over there now. Get the same accurate and reliable meter that we use.
Great question. And it is a concern. And there have been people who said, oh, these medicines, the GLP-1s, cause muscle loss. And that's been an inhibitory kind of commentary or idea for many people when it comes to using them. But here's what we know. If a person takes a medicine of any kind or loses weight for any reason and they're sedentary, they're going to lose fat and muscle both. And probably preferentially, even in that situation, if they stay sedentary, they're going to lose more that is fat than muscle. And typically the first fat loss is the visceral, the abdominal fat, and that's what you want to lose. That's that rapid turnover fat. So that will go first. Yet, if a person maintains a certain amount of activity, and I would say it's always important for a person to be active, walking like 150 minutes a week or whatever a person does. Many people do much more than that, of course, like lifting weights, that kind of thing, resistance exercise. Those people are not going to have much muscle loss when they use a GLP-1 or when they lose weight for any reason. This is really a weight loss phenomena. It is true that when a person loses weight, especially a substantial amount, that some muscle areas are just not needed as much. They're not having to carry as much weight. So they might lose those muscles a little bit. There have actually been some pretty good studies done that have looked at body composition with GLP-1s and the combined GLP-1 GIP med. And remember, we're talking about GLP-1 glucagon-like peptide 1, and the GIP is glucose-dependent insulin-tropic polypeptide. Those are the abbreviations. We use GIP for that one, and then GLP-1. There's been some pretty good body composition data that shows that, yeah, people can lose a little bit of muscle, but mainly they're losing fat. So I'm not worried about muscle loss when people use GLP-1s unless they're completely sedentary. And one of the first things I'm going to recommend that people do when they take one of these meds, I say, be active and burn some calories too. these medicines reduce calorie intake, but also it's very important that people burn calories and use their muscles.
I have to say, I've been wondering about this question for a while, because did someone just say something in public and it just stuck? You know what I mean? Was it like a knee-jerk reaction or one of their first things? Like, even would you go back to them now maybe and they'd say, oh, I've looked further and I agree more with what I just heard. So I'm glad you were able to answer that so completely. Thank you.
Yeah, Scott, I think some of these studies that have been done with body composition will be published and will become more common knowledge. And it's an important concept. It's an important question. And it's important that we advise people to, do their own thing about reducing calorie intake and also increase muscle activity when they're using these meds.
Yeah. I saw a big difference just adding like low intensity, like dumbbells from my arms, my chest, my shoulders.
Yeah. I'm glad you said that too, because your experience is very important. You don't feel like you've lost muscle mass, and you're doing activities, you're lifting weights and that. And I'm not talking about heavy, and you're not either. We're not talking about heavy duty weightlifting. No. We're just talking about light weights.
Resistance.
Resistance exercise.
I'm also very careful to mix a fair amount of beef and chicken into my diet for protein too.
Yeah. Good.
Yeah. I'm going to jump off the list for a second. This is actually a question that came in to me through somebody I know personally. So they start Zepbound for weight loss. This person does not have diabetes.
Yes.
But they were pretty significantly overweight and not just hungry, Dr. Blevins, but like ravenously hungry 24/7, like could eat to being stuffed and someone could offer them a dessert and they go, yeah, bring it on. Like that kind of thing. Knowing, sitting there thinking, I'm not hungry. Not only am I not hungry, my stomach hurts, but yes, I'm going to eat this.
Right.
They go on Zepbound. It took a couple of months and the food noise did not go away for a couple of months. And I said to them, just keep going. It will. And one day I get a text. It's working on me all of a sudden. Like I'm starting to lose weight. I don't feel ravenously hungry all the time. I'm filling up quicker. It took months for it to start working for them. And they're having success. They lost 14 pounds. Things were getting better. And then all of a sudden, the doctor does the blood work and they have a significantly increased lipase and amylase. So lipase 394, amylase 204. Doctor pulls them off the med, and those numbers go back down. So my first question is, are those bigger numbers a reason to say, oh my God, pancreatitis is coming, get off the med? Or is that just a thing that happens?
Well, that is a great question. And I'm not sure I have the perfect answer here either, but we've done quite a number of studies and I can talk about published information. And it is clear that those enzymes can sometimes go up and down and while on treatment. The question is, what happens in people who are not on those meds at all on a day-to-day, week-to-week, month-to-month basis? And we don't know. There are really hardly any studies, if any at all. I don't think that I can cite one that looks at amylase and lipase. And as you said, those are, for the audience, those are the enzymes from the pancreas. And they tend to be really high when people have pancreatitis. Well, keep in mind that pancreatitis is a clinical syndrome of pain, like bad pain, and inflamed pancreas and very high numbers. So what does it mean when those numbers are high and a person is not having pain? We don't know. And of course, I agree, those numbers are depending on the normal range. Depending on the normal range in that lab, those numbers are concerning. And I do understand the concern of the doctor there. And using a medicine that, remember, these medicines stimulate the beta cells to make insulin. They affect the alpha cells that make glucagon in the pancreas. Any med that might affect the pancreas could maybe inflame it. But there's really no clear evidence that these meds do that. Mm-hmm. So I agree with the concern. It's an unknown. And this is going to be a clinical thing there with the person who was on the Zepbound. That person I know will be talking to the doctor further. And do they want to reintroduce the medicine? That's a judgment call.
Yeah.
Is it pre-pancreatitis? Who knows? That's a great question. Do I normally measure lipase amylase? And do we always routinely do that? No. Was there a reason in that patient, in the person you're talking about, to measure it? Were they having some pain? Maybe. I don't know.
And Tom, absolutely but no pancreatitis
symptoms at all.
Not one at all.
So it wasn't pancreatitis.
Nope.
Almost certainly. That one's going to be a call it as you go.
Mhm.
And do I recommend that people check amylase and lipase? Not really. Everybody has a different level of caution. Some practitioners may want to check them along the way, and that's their call.
Yeah. All right. So here's another one that's not on the list. Person using medication for mood stabilization and anxiety.
Yes.
Starts using a GLP medication for weight loss, and then it messes up the absorption of their medication and their anxiety gets significantly worse. Is there a way to manage that? They're already on a large dose of the anxiety medication. The doctor was uncomfortable giving them more, and that's why they took this person off the GLP. But was there a better way to manage that you know of?
Again, that's going to be very much a clinical thing up kind of between the person you're talking about and the doctor. Would a lower dose of the GLP-1 work and make it all okay? Maybe. Would timing help of the medicine? Maybe, but not horribly likely, because as you know, these GLP-1 meds, like the ones we use, are once a week and they have a very long life. So there's not really a predictable time during the day that the effect would be less on the stomach emptying. Right. Would it gradually improve over time? But not hard to know. As you know, the effect on gastric emptying that these medicines have, the slowing down of gastric emptying, is something that happens especially early on when you start the medicine. And every time you increase the dose, it kind of recreates itself. But the gastric emptying kind of goes back a little bit more towards normal after a person's been on the med for a while. And after a few weeks, it doesn't go back to normal. That's going to be very much a play it by ear thing. This is why the people say it's the art of medicine, not just the science. And that's going to be an art thing.
I asked the question here just so people can hear, like, if you are taking medications by mouth, you might be seeing absorption changes. It is a thing to take, that
is true.
Take note of. All right, let's stay in that vein a little bit. I have gastro problems when I use these drugs. I have a very low carb diet, which helps me keep my numbers in 5-5 range, but I need to lose weight. Low carb means high fat some of the time, which can make me sick with the drugs. Is there anything that can be done to help me use GLPs without so much sickness? This episode is sponsored by Medtronic Diabetes. MedtronicDiabetes.com/Juicebox. And now we're going to hear from Medtronic champion, Jalen.
I was going straight into high school, so it was a summer heading into high school.
Was that particularly difficult?
Unimaginable. I missed my entire summer. So I was going to a brand new school. I was around a bunch of new people that I had not been going to school with. So it was hard trying to balance that while also explaining to people what type 1 diabetes was. My hometown did not have an endocrinologist. So I was traveling over an hour to the nearest endocrinologist for children. So, outside of that, I didn't have any type of support in my hometown.
Did you try to explain to people, or did you find it easier just to stay private?
I just held back. I didn't really like talking about it. It felt like it was just a repeating record where I was saying things and people weren't understanding it. And I also was still in the process of learning it. So I just kept it to myself, didn't really talk about it.
Did you eventually find people in real life that you could confide in?
I never really got the experience until after getting to college. And then once I graduated college, it's all I see. You can easily search Medtronic champions. You see people that pop up and you're like, wow, look at all this content. And I think that's something that motivates me. Started embracing more, how I live with type 1 diabetes.
MedtronicDiabetes.com/Juicebox to hear more stories from the Medtronic champion community.
Yeah. This is a question that has many different components in a way. And keep in mind that fat does slow down the stomach emptying already. And then you add a medicine on top of it that slows it down, and you get a double slowing in a way. Maybe not double, but you get more slowing, and that can lead then to more nausea and even vomiting. And so one of the strategies, of course, when people start a GLP-1 or GLP-1 GIP med is to reduce the fat. So those of you out there who are taking these meds, if you have a high-fat diet and you're taking a GLP-1, cut it back, because that'll help the nausea if you're getting nausea. Low carb doesn't necessarily have to mean high fat. Low carb can be accompanied by kind of a lean protein type, a lean meat type intake, and it can be okay in terms of weight loss. So I would say that though it's not as simple as I might try to make it here, that the person here doesn't have to go high fat. And I think they could modify down to, and I think low carb in my mind is many different definitions of different definitions of low carb. I think it's low, simple carb. I think vegetables fit very well into a low carb diet. It's the potatoes, pasta, rice, bread stuff that I try to get people to avoid.
Yeah.
More simple carb and other simple carbs too. So I think the vegetable lean meat approach would be okay.
Mm-hmm.
And so I hope that helps the person if they take that approach.
I think it might, actually.
Yeah.
Here's one. I've been on Ribelsis since mid-February. I'm type 1. I'm taking it for weight loss. My A1C is 6.8, no side effects. I've gone from 190 to 169 pounds. Now, today, my endo said she's really concerned with me using a GLP medication, being a type 1, and then notes the risk of pancreatic and thyroid cancer. Is that a genuine concern?
Okay, so a couple things. I'm always going to want to kind of refer back to the idea of the approvals. And I know this is being used off-label for this patient. In other words, you know that Ribelsis is not approved in type 1.
Right.
We've talked about this before. And Scott, I'll continue to repeat that because it is up to the clinician and the patient to decide many of these things. It's called off-label use of a medicine. So that's one thing to say. Congratulations to the person who has such a great A1C and weight loss. That's great. So this is going to be a discussion that's going to be important for the person to have with their endo and go back in and say, hey, tell me more about this. And let's talk about it. And I certainly don't want to get in the middle of that. I will say that the thyroid cancer issue with GLP-1s and GLP-1 GIP meds, and it's a boxed warning for virtually all of them, has to do with a cancer called medullary thyroid cancer. I'm not going to go as far as say it's rare, but it's really uncommon. And it runs in families many times, not always. There's something called multiple endocrine neoplasia syndrome type 2 it runs in. And we do see people, I'm an endocrinologist, and I see people who have MEN too. And I would never give them GLP-1 meds because it's contraindicated, because there's cells in this thyroid called C cells that were stimulated in rodents when they were given GLP-1 meds. Now, humans aren't rodents, but we don't know the whole story here in terms of how humans might respond who have either the cancer or family history. We don't know if it would promote it. So those people shouldn't take it. Most thyroid cancers have absolutely no implication when it comes to GLP-1. There's no sign that GLP-1 meds can cause the common kinds of thyroid cancer. So that's something the person needs to talk to their endo about a little bit to try to find out more about that. And if the person has no family history of medullary thyroid cancer and no family history of MEN, multiple endocrine neoplasia, then they could go in and talk to their endo about that. Pancreatic cancer, there's really no evidence that these meds cause pancreatic cancer. And so I think the person wants to go back and talk to their endo and say, let's talk about that issue. What are we talking about here? I think that's the best approach. Go back in, talk to the endo and find out more about the concerns that we know.
Yeah, I'm going to read you something, then I'm going to ask you a question about how you think about things. So
yes.
Medullary thyroid cancer is a rare type of thyroid cancer accounting for about 1% to 2% of all thyroid cancers in the U.S. Approximately 1,000 people are diagnosed with medullary thyroid cancer each year in the United States. So if you're one of those 1,000 people, then your odds aren't great. But that's a pretty low number. And that's fair to say, right? 1,000 people is a fairly low number?
That's a pretty low number.
Okay.
I agree with the concept. I think 1% to 2% doesn't fit rare, but it's really, really uncommon. Mm-hmm. I know it's called rare. It's really, most thyroid cancers are called papillary or follicular or mixed. Those are the ones that we see. If someone has that kind of cancer in their personal history or family history, there is no contraindication to using this med. Right. So you're right. One thing to point out is, and we don't want to go too far here, but these meds have been around for quite some time. Ozempic was approved in 2017, and Trulicity's been out for a long time, and it's been used in millions of people. And we're not seeing a thyroid cancer medullary or any other cancer signal. And now, you could say, well, it's not being followed very closely. I mean, how would you know? Because there's not a study going on here. But people do report these things. There is no signal that's showing up. So I think it's very important that a person not take GLP-1s if a person has a personal history of medullary thyroid cancer or that multiple endocrine neoplasia syndrome. But we're right. It's really, really, really uncommon.
So my question to you is, because you're a common sense person, this is one thing I've learned from you in the short time I've met you and known you. In your own life, medications you might take, or as a doctor who's prescribing, how do you think about the problem of, yes, some people die in car accidents, but we need to drive when it comes to medicine? Like, do you know what I mean? Like that bigger idea, because you hear people all the time, like, I'll post on the Facebook group, hey, we're talking about GLPs today on the podcast. And 50 people will be like, oh my God, I've been on a GLP for 2 years. I've lost so much weight. My A1C is down, blah, blah, blah. It's all, and one person's like, it makes me throw up. And everyone goes, oh my God, it makes people throw up. It's a really interesting way our minds work. Like, I know we're risk averse as humans on purpose, and that's a good reason. But
right.
How do you think about it personally? Like when you're standing in front of a person, you decide to give them something, and this and whatever else is in that label is out there. How do you make the risk reward decision?
Yeah, it's what you said. It's a benefit risk equation. It's a benefit risk analysis. You want the benefit, the potential benefit when you start a medicine. When I write a medicine, I want the benefit, the potential benefit to way exceed the risk. And risk is a very, very thing too. I mean, some medicines have a risk of some really nasty things. Some medicines have risk of some fairly mild things. And so nausea can be anything from mild to nothing to terrible. It is true. And I tell people this all of the time, or if I'm ever presenting this data, I say, well, some people can't take it, for sure. Mm-hmm. And that's true of most meds. And that's when I take a med, I know I'm going to try it. If I'm having a symptom I don't like, I'm going to stop it. And I'm going to look for an alternative maybe. It depends on what. It's all about the condition and the benefit and the risk. And so people need to know going into taking this type of medicine or any type of medicine, why they're taking it, what it can do for them, and the risk. And they need to realize, especially with GLP-1s, that sometimes people just simply can't take because of nausea. Yeah, if one person has nausea and vomiting and they stop taking it, is that a clarion call to say everyone should go off of it? Not at all. Not at all. Right. The vast majority of people have no problems with it. They might have mild nausea. They may have moderate nausea, or even notable nausea, which tends to get better over time. It doesn't always get better over time, though. And I'll tell you, if you look at most of the studies, I'll just kind of ballpark it, anywhere from 4% up to 8% of people in the studies had to discontinue the GLP-1 or GLP-1 GIP meds because of GI symptoms. And as we've talked about before, that would be nausea, vomiting, diarrhea, constipation. I tell people, hey, you may get nausea, vomiting, diarrhea, constipation, and you don't get to choose, one of those, and you may not tolerate it. Many times we can mitigate we can reduce the side effects by reducing the dose. And there are other things I could go on and on about that can also reduce the risk of that, like lower fat. We talked about that a while ago. Mm-hmm. Lower volume in the food intake. There's lots of things people can do to modify, but yeah, you're right. If one person has a significant side effect and they can't take it, that's interesting. And that's it. And I'm sorry for that person.
Of course.
It doesn't mean other people should go off of the medicine.
Or not try it either.
Yeah.
Yeah.
Exactly.
My mindset is simple. Like, we're here now. Like, the rules have changed. Like, I'm not standing in front of you, me personally, super fit, muscular, with no fat on me and no risks of heart attacks. I'm 52. I'm carrying extra weight. A lot of it's in my stomach. You give me this medication, I'm not as hungry. I fill up sooner. I'm losing weight, and I have diarrhea. Feels like the cost of doing business to me. You know what I mean? Now, it wasn't so bad that I couldn't exist. And of course, if it was, that would change it. I want to know too, and this is going to call for speculation, but how many people have you stood in front of who experience these side effects and you think, yeah, stop taking this? And how many of them do you think, tough it out, it'll be okay? And like, is sometimes it's just the resiliency of the person, not necessarily the medication. I know that I'm not blaming them, but I mean, people do have different tolerances for trouble. Do you know what I mean?
They do. Yeah. They do. You know, the answer is it's highly variable. I had a person in the office yesterday who was having pretty bad constipation connected to a GLP-1 med. And we did a few things. First of all, she didn't want to stop the med because she's had good results. And just what you said, she's had good results. She understands the importance of the results she's had. Her sugars are better. Her weight's down. Everything's better. She feels better. Mm-hmm. But she has pretty notable constipation. So what do? We cut back the dose a bit. I give her some advice about treating constipation in general. And there are ways to deal with it. Now, some people come and say, it's so bad, I can't take it. And I go, hey, you're the boss, not me. Mm. And let's go off of it, or we might try a different GLP-1 GIP med. Surprisingly, sometimes changing the med can change the symptoms. And you wouldn't think it would be true. You would think that all be kind of similar in that way, but there are some differences.
My endo told me going from Wegovy to Zepbound might help me with loose stool.
Yeah.
Yeah. And she indicated that it's possible my acid reflux, which had gotten much better, could actually even get a little better again.
Yeah.
It has been my finding. I had known enough about the drug before I started, which I think people should know, that I was very careful to take magnesium oxide every day when I started the medication. Like, I did not want to be constipated. And I also very thoughtfully, even though I'm not a high fat person to begin with, I was extra careful not to eat high fat. Now, I mean, the truth is, depending on the dose, I've had, it's funny, I've had French fries in front of me at a table with a bunch of people, and I've reached down and had 2 or 3 of them. And you get to the third one and you're just like, I don't want this. And it's interesting how your brain works so much differently on this med than it worked for me, than my brain worked without it. Because I could have eaten them, but I was just like, I don't want to do this.
And that is so cool because you just saved yourself a few hundred calories.
Yeah.
And that is the way those work. The meds work. They do such a nice job with that.
Fascinating.
Yeah.
Let me ask you one. It's a little generalized, but just so that this information's in each episode that you do about GLPs, this question: what specifically is it about a GLP that helps lower insulin needs for type 1s? And is there one that is preferred over another specifically for type 1s?
Well,
so forget for a minute FDA approved.
Right.
We know none of them are for type 1s, but what's the mechanism of how a GLP helps lower your insulin needs?
Yeah. And you're right. None of these are approved for type 1. And we are doing a study, as we've talked about before, here in Austin, that's looking at one of these in people with type 1. And I hope that study pans out to show it's effective and safe. And maybe we'll get one approved. We sure hope so. But the way it could reduce insulin needs would be, number one, it does slow down gastric emptying. So therefore, anything that goes in gets absorbed more slowly. So there's less peaking of the carbohydrate, less glucose flow from the intestine. At least it's delayed. And so that's a better way to put it. In addition, the medicine can reduce appetite a bit. So fewer calories in, fewer carbs in, lower glucose and lower insulin need. It can reduce then weight as a result of the decrease in appetite or early satiety. And that improves insulin sensitivity itself, as you know. Now, is there one that's preferred? I don't know. And I don't think so. Mm-hmm. I will say that the one called tirzepatide, which is Mounjaro, and Zepbound, has the effect that the GLP-1 has on slowing emptying and reducing appetite, but also seems to increase insulin sensitivity. And so that's an interesting phenomenon too. Everybody's still kind of working their way through that one. So it has that effect. So all of those mechanisms together, or even individually, can help reduce the need for insulin.
Mm-hmm. 2 follow-up questions. So one for me personally, if it's slowing gastric emptying, meaning I'm probably going to bed with food in my stomach. How is my stomach acid going down? How come it's having that impact? For the life of me, the first time I laid down at night and I thought, oh God, I don't think my dinner's like through me yet. And I expected more gastric reflux and I got less. What's the mechanism there?
Yeah. Here, this is going to be something that varies from person to person. These meds can cause a worsening of reflux because they slow emptying. And that's what you'd expect. And some things happen that we can't explain. I will say this, when a person loses weight, they lose visceral adiposity, visceral fat early on. They don't lose it all. They lose some of it. Mm-hmm. And that reduces then pressure on the stomach. That's just a mechanical thing. That reduces reflux. And so, and perhaps a person eats less as they use the med too, and that might reduce volume, and that might actually reduce pressure in the stomach, and the pressure is what leads to the reflux into the esophagus and the acid feeling. So there are a number of possible reasons that your symptoms are better. One may be the weight loss, the reduction in adiposity, visceral fat, and the other may be that you're eating lower volumes. Okay. And maybe you're not even noticing you are, but possibly you are.
I notice.
It does not have intrinsically any anti-acid effect, I'll tell you that.
Right. So it's more physical, structural implications.
I think so.
Yeah, it makes sense to me. I'm going to ask a very specific question. This is actually for like an acquaintance of mine.
Yes.
At birth, this person lost some of their intestine, so it had to be removed. Their whole life, they basically eat and then dump, right? Like that's how it goes. Right. Would a GLP be bad for them with that structural change?
Interesting question. And this may also more generally be something people who with gastric bypasses might ask, or gastric sleeve too. And the answer is, first of all, the best answer is I don't know. The other part of the answer is that person, if they wanted to explore that, would need to talk with their doctor and find out, the pros and cons and whether it's even possible or feasible. And the answer is it could, in theory, because it slows down gastric emptying. It slows down the lower intestine as well in many people. So how's that going to work? I don't know, but it's an interesting thought.
It's not a question that makes you like throw up a stop sign and go, oh, hell no, don't do that.
No.
Yeah. Okay.
No. This is one of those things, it's a negotiation with the doctor.
Of course.
Or that person may have a GI specialist. I don't know, but it's a negotiation like so many things. It's, well, what about this? Would it be worth trying? And that's where I would take it.
Listen, that's what I told them, especially when this would be for weight loss for them, not diabetes. I said, my God, they're going to give you a quarter of like Wegovy to start. Like, I don't think you're going to get thrown into a giant problem. And if it's a problem, you're going to have to live through it and stop, so.
Yeah. Probably, Scott, probably the only GI history, and there's some I might, in general, that I would say is kind of a contraindication to using the meds would be if somebody has established gastroparesis, then adding a medicine that slows down the stomach even more, just generally speaking, not a great idea.
Yeah.
Most of these, it's recommended you don't use them when people who have gastroparesis. Has it been studied in people with gastric sleeve or gastric bypass, or a person like the person you're talking about? No. And could it be tried? Possibly. You'll know pretty quickly if it's a problem.
Yeah. I have a note here to myself because I knew this would probably come up at some point, talking about the difference between a person with type 1 who starts to experience digestion issues, maybe because your pancreas has been impacted the way it has been and you're not getting digestive enzymes maybe correctly from your pancreas anymore. People don't know that. But the frequency that I hear from newly diagnosed people, or my son has stomach issues now that they have type 1 and they've had it for a year. For some reason, a lot of endos don't talk to type 1s about using a pancreatic enzyme or a digestive enzyme, to help with digestion, or maybe add a magnesium oxide to help with elimination. And instead, they end up eventually at a gastro who just says, oh, if your stomach's emptying slowly, you have gastroparesis. The difference between that and someone who's had type 1 for 30 or 40 years and likely has nerve damage if they have gastroparesis. And I do think there's going to be a section of type 1s who GLPs aren't going to be a choice for because of actual gastroparesis that's affected that. Is it what is that nerve called? I feel like it starts with an F, but I can't think of the name of it all of a sudden.
Phrenic is one of the nerves, but vagus nerve is there. And I mean, some people with type 1 do have that neuropathy, the autonomic type neuropathy, which leads to gastroparesis. And some of them don't know they have gastroparesis, and they might find out of course, it would be off-label if they used a GLP-1 type med.
Yeah.
And I've seen that, and they're going to have more notable. And there could be people who have gastroparesis who have had diabetes a short period of time, but it's probably not caused by the diabetes. And so there are certain tests like a gastric emptying study, which is kind of a funny study where people may have to intake some food that's got some radioactive stuff kind of mixed in with it, and then it's observed. The emptying from the stomach is observed after they eat it.
Yeah.
But that kind of a test is an objective way to look at gastric emptying.
I just want to bring it up because there's a lot of thinking to be done around this issue around type 1 and GLP meds, I think.
Yeah, I think you're right.
Scary scrambled eggs aside that they give you for that test.
Right.
Yeah, there's stuff to be considered.
Sounds kind of awful.
Yeah. Would it be better, GLPs they mean, than taking metformin? I'm asking because my teenager has major insulin resistance and weight gain.
Yeah. Metformin has a little bit of, there's data in type 1 diabetes with metformin, and it can help a little bit, but it's not very consistent. Metformin primarily seems to reduce hepatic, that is liver, glucose output. Is it an insulin sensitizer? Can it treat insulin resistance very effectively? The answer is, well, in general, it's not a classic sensitizer. Can it lead to weight loss? Not very often and infrequently. Occasionally, though, people get sort of almost like anorectic on metformin, and we have to take them off. And that is very unusual. So I think metformin has a potential role. It might be worth a try. It is, of course, it's not approved for type 1 either, but we try it at times. And so I don't think, metformin might have some effect. Scott, what was the other part of that question?
They have major insulin resistance and weight gain.
Yeah.
So, I mean, let me ask you a different question about metformin, and we'll circle back around. It's one of those drugs that's used a lot by biohackers, like with the idea of like metformin fixes everything, makes you live long. Like, is there any studies that tell me that just popping a metformin is good for my longevity?
There's a lot of theory here, and metformin may have some anti-inflammatory effect. There are people that feel like it has some effect on reducing dementia and has an effect on longevity. The data is not in on that one yet. Mm-hmm. And there's some studies going on. Actually, there's a large study going on to look at that kind of thing. But it's going to take, that kind of study clearly can take a while to finish. And there'll hopefully be some stops along the way that we'll get information. But the answer is unclear. Yeah. Does it lower glucose and sugar? Yeah, it does. And is it good for type 2 diabetes? For sure. Is it a strong med? Not really. It's a kind of a weak med when it comes to lowering glucose. It plays well with virtually every medicine that we have in the type 2 space. And we do use it off-label sometimes in type 1.
Okay. But GLPs are leaning towards impacting some similar ideas with, like, I mean, right away, what's the one that they wanted? They were trumpeting, like heart disease with GLPs is down, and what else? Kidney disease. But is that just a function of keeping weight off and or blood sugars lower?
It's not really clear. I think that's a lot of it. But that semaglutide, which of course would be Ozempic, Wegovy, Rybelsus, the Ozempic component that is looked at people with type 2 diabetes and with existing heart disease, and found that there was a reduction in what's called major adverse cardiovascular events, and that would be cardiovascular death, and then also non-fatal MI, heart attack, and non-fatal stroke. So is it because of the weight loss? Hard to know. Is it because of the consequences of weight loss? Probably, yes. The lowering of blood pressure, maybe improved lipids, other anti-inflammatory, other effects we don't even know about. And maybe so, but in people with known heart disease, cardiovascular disease, and type 2 diabetes, Ozempic has really good data.
Yeah.
And that Wegovy recently, which is, of course, the same thing for the weight loss, is semaglutide. Wegovy recently was approved to reduce the risk of those major adverse cardiovascular events in people that have known heart disease and either obesity or overweight. So we know that these meds and other meds like Mounjaro, Zepbound, they're being studied in the same way. Trulicity showed improvement. Trulicity's dulaglutide, the other GLP-1, liraglutide showed that too. So that whole area is very good. Usually, though, I'll point this out. They're looking at people who have known cardiovascular disease. They're not looking at people who have type 2 diabetes and don't have any known disease. And they certainly have not looked at people with type 1. Kidney, yes, there's some good data that shows that these meds, and specifically semaglutide, might actually have a beneficial effect on the kidneys.
Interesting. Let's do one for people who are using now. What happens if I go up and down on my dose because of the shortage of the medications? Is that going to hurt me?
And the answer is it's going to be really annoying. And it's going to hurt your feelings for sure. And I don't think it's going to hurt you. You're going to have to chase the glucoses a little bit when you go down on the dose, or if a person, for example, can't get one dose, but they could get the lower dose. The pharmacy has the lower dose. They don't have the dose they're taking. Well, the lower dose is going to be less effective. And the person might have to adjust their glucose, sugar lowering meds a little bit, and they may feel differently. And then, in 1 or 2 months, they might get the dose they were on that is now the higher dose, and they might have to reduce their meds a bit. Is that going to hurt you? I don't think so. Is it going to annoy the heck out of you? Yes.
Yeah. It's almost like somebody's going to reach in and change your basal rates or something like that without telling you.
Right.
And even if you're just on it for, I'm seeing people who are just on it for weight loss, they don't have diabetes, and the same thing's happening. They call their pharmacy, and their pharmacy's like, yeah, we don't have it. And, but we have this one. And you go, all right. I mean, some's better than none if it's lower, but you can't just go from, like, for example, you can't just go from 5 milligrams of Zepbound up to 12 because that's what they have. That'll crush you, right?
That could be a problem.
Yeah.
And I think some people could probably tolerate that, but we don't know. And the whole idea about going up slowly is just what you're implying, is so that you maintain your tolerability of the medicine. Mm-hmm. And going up too far, too fast could bring out GI symptoms that you wouldn't have had otherwise. So you're right. It's a funny world right now where the supply is difficult. I think there's been some improvement recently. We're talking right now at the late May 2024. And I think by later in the year, the supply is going to be better. I will tell you this, though. I said the same thing last year at the same time, and the supply didn't improve that much. Demand is so high for these meds that it's been hard for the companies to keep up with supply.
I think there's an indication there, by the way, that because the demand is so high and consistently high and grows, that should be some indication that it's working for people. Because sure, everybody might want to try it, but if you try it and it doesn't do anything, you're not going to keep doing it. It's obviously at best, just me guessing out into the world, but I don't imagine there'd be this trouble locating. I mean, I've run around looking for this stuff like a crackhead a couple of times. You know what I mean?
Right. Yeah.
Hard to find sometimes.
Hard to find.
And CVS Caremark just announced they're just not going to carry it anymore through mail order because it's so inconsistent, their ability to get it. But that explains the moving around in doses. I'm into my second week of 10 milligrams Zepbound, and I had plateaued on Wegovy. I just wasn't losing any more weight on Wegovy. I got moved to Zepbound. My doctor, I think, started me at, 2.5 maybe with that. I quickly went to 5.
Yes. I
lost 6 pounds, but and then they put me on, I plateaued. She put me at 7.5. And 7.5, just nothing. Like, I started to gain those 5 or 6 pounds back that I lost with a switch. And now I'm on 10 for 2 weeks, and I've lost those 6 pounds again.
Right.
And everything's back to where it was, meaning I started to have sugar cravings at the end of when I was on lower dose of Zepbound. Now that it's higher, the cravings are gone. The weight loss is happening again. It's fascinating to watch, but you really do have to pay attention.
You do.
Yeah. I make a diary of it. I do it on the podcast, but I think if I wasn't making the diary, I wouldn't even be able to keep up with what's happening to me. I think that's my little bit of help. I think you should make a diary about it if you're on it.
I think that's a great idea.
Yeah.
And I think I'm really glad you said what you did about titrating. You increase the dose and then that you had results on the weight loss side. And because sometimes people will start at the lower doses, nothing's happening, this is not working. And, hang in there, titrate the dose. You get up to 7.5 of Zepbound, 10, 12.5. Sometimes people at 10 don't get results and you go to 12.5 and it works. And there's a chance, there are always people that don't respond to any dose, that's for sure. But usually titrating up is going to allow a person to get some results. And that goes for Wegovy, that goes for all of them.
But Dr. Blevins, you're sitting here with this grand amount of knowledge and you're articulate about it. You know how to explain it in a way that people can understand. A lot of people don't get that from their physicians. Some of their physicians are making decisions based on what they hear on Access Hollywood. You know what I mean? I hear it's making people throw up. You don't always get real thoughtful advice. And even the advice I'm getting is from a very learned, level-headed person. You know what I mean? And I have good communication with her as well. If I texted my endo right now, she'd text me back.
Oh, that's great.
That kind of if I said, hey, I'm doing this and this happened, what do you think I should do? I'm thinking this, I'd get a note back.
Yeah.
And not most people don't have that, you know.
And it is important to realize that people who are prescribing, there's that thing in medicine called do no harm. And you don't want to make people sick with your medicine. And so realize that the audience realize that, you may not tolerate the medicine and you're communicating many times back and forth, just Scott, as you said, by text or by phone or by, portal message or whatever. And you can't express exactly what's going on. And then the person on the other end is going to read if the person says, hey, I can't tolerate this medicine, they're going to say, oh, you want to stop it. But there may be some middle ground there. And actually communicating in person or, more completely can really make a big difference.
And stop knee-jerk reactions from happening too.
Yeah, exactly.
Yeah. Do GLPs reduce inflammation in the body? And has it shown any benefits for other autoimmune issues?
Yeah, that's a great question. And that's the hotbed of a lot of research and a lot of discussion and a number of studies. And the answer is, if you look at the studies that are so far available, you can see some reduction in markers of inflammation. Is that going to translate into some really, good treatment for inflammatory conditions? I don't know. I don't think anybody knows. If somebody has rheumatoid arthritis, does a GLP-1 help? Who knows? I wouldn't predict yes, because I don't see how that can happen. But maybe there'll be something down the road that'll tell us more. If a person has, say, osteoarthritis, the bone on bone in their knees, hips, does losing weight help that? Of course it does. And so a lot to learn here.
Is AstraZeneca developing a GLP that you know of?
I know that Boehringer Ingelheim is developing, and also there's some other companies developing, a company called Structure. I'm not aware that AstraZeneca is, and I'll just be the first to say I don't know everything here. We do a lot of clinical research here, and there may be things going on I don't know about, but I suspect that question was about Boehringer Ingelheim. The bigger answer here is, there are a number of companies that are developing new GLP-1 meds, GLP-1 GIP meds, and even those are dual agonists, and they're triple. And there's a whole wave of new generation meds coming through, and they're going to have different characteristics, and they're going to have favorable characteristics, we think. So, hold on, and as you might expect, there's a lot of attention in this area in the pharmaceutical research industry, and there'll be more meds coming down the pike.
Let me read you this, and I'll tell you what I think. ChatGPT-40 says AstraZeneca is actively involved in developing a GLP medication. They have recently acquired the rights to a promising oral GLP-1 agonist called ECC5004 from a Chinese biotech company called Echogene. So,
good.
Yeah. So
great.
Let everybody
keep trying. It makes total sense. AZ is a big company, and many of the big companies have focused a little bit more on this area. So that is great news.
I'm also excited for biosimilars to start popping up, because obviously these things are working for people. It's hard to turn them out. Some of the molecules work better, and for some things, some for others. I think it can only benefit to have options, and a fresh set of eyes doesn't always hurt either when people are trying to find something that does the job but isn't copying, because that's the real problem right now is that people have patents. So you can't, nobody can knock it off as a generic yet. That's not going to happen for a while. And so if you want there to be more innovation, you've got to have all these companies looking at this at the same time. So
that is so true.
Yeah.
And, this thing about these meds and their effect on what you talked about, appetite, and one of the people who asked a question asked about appetite. And these medicines help regulate appetite, which appetite gets people into trouble. And you have 3 French fries and you stop. That's great. Most of the time, over the past, if you're me, a few French fries, I'll go, man, that looks good. I'm going to have that whole basket. Mm-hmm. And if something could tell me to stop, that'd be really good and very healthy. It would be interesting to see these meds approved just for appetite reduction. Although that's probably going to happen because I don't think the FDA is going to allow that approval for something. They're going to want a disease condition, but appetite is frequently the root cause. And these medicines reduce appetite, all of them.
I'm waiting for agri companies to start getting involved and trying to put a stop to them, because you know what I mean? If I made Oreos, I'd be scared. Seriously.
Yeah, that's a good point.
Yeah, no kidding.
I don't think Oreos have anything to worry about.
Yeah, I'll tell you what. They're hard not to eat.
Show me an Oreo and I'll eat it.
Is there any concern with long-term use? For some people, listen, this is me looking online, right? I've seen some people say, I lost the weight, I lost the med because of my insurance, and guess what? I'm fine. I didn't get any back. I learned how to eat better. Everything's going well. I'm active, etc. I've seen people say, I've lost the med because of insurance, and I didn't change a thing about what I was doing. I put all the weight back on. So right. Some people are going to have to take it forever. Is there a safety concern with that you can think of?
Forever is a long time. And we have a lot of data with these meds, and we don't have 20-year data yet. Trulicity, Ozempic, they've been out, we talked about this earlier, been out a pretty long time. And so far, no new signals have shown up, like some weird findings. And so they look safe for long term. In general, I would say that for a person to maintain the effect of the med, most of the data says the person has to continue the med. They might be able to reduce the frequency of administration and the dose to maintain, but they're going to need to continue the med. There are going to be exceptions to that rule. There are going to be people who can stop and maintain. That is great. And there are going to be people who take it on and on and on, and they regain. But in general, if you continue the med, the effect continues. So everybody's looking in the scientific community to look and see if there's anything long-term that turns out to be a negative, but so far so good. So it's not only the duration of time people are on it, but the number of people. And there are really millions and millions and millions of people who've been on these meds now, and no clear new signals have shown up.
Yeah. Do you have a little more time, or are we done?
Yeah, we can go. How about we could aim for another 10 or so?
10 minutes? Okay. I like to know if GLP is used in patients with thyroid concerns, Hashimoto's specifically, and or hypercholesterolemia. Is that what that is?
Hypercholesterolemia, yeah. I think is what they're saying.
Yeah,
where is that one?
Are there concerns with that?
The answer is there's no sign that GLP-1 meds or GLP-1 GIP meds can make Hashimoto's improve or worse. There's really no evidence there. And there is no evidence that these meds would make cholesterol worse. In fact, if you look at most of the data, you would see that the cholesterol levels improve. I could go through each fraction. I'll just say they improve when people are on these meds, probably because of the effect on weight loss. There's no sign that there's a direct effect of these meds on cholesterol synthesis or absorption or any of that, but weight loss is magic when it comes to improving cholesterol.
I'm going to ask one for myself, and this is about you specifically in your practice.
Yes.
You deal with a lot of adults.
Yes.
If I was your patient and I came in and I said, hey, here's where I'm at so far, and you've watched me for the last 13 months, and I said, I want to continue to make my body stronger and give myself the best chance to live longer. If I said, I don't know anything about this, Dr. Blevins, but should I be on some sort of a testosterone replacement? Is that a conversation you would have with me, or do you not see the value?
I would definitely have the conversation with you about that. And what I would do, I would first of all ask you about any symptoms related to low testosterone, and then I would check your levels. And then if you're low, I would say, your bone, your muscles, your mood, many things in your body will do better if you're normal. Would I put you on testosterone if I find you to be normal? And the answer is I wouldn't. There's no evidence that putting people on testosterone who have normal levels is going to prolong life or improve things. And so it's another one of those benefit risk things. If you're low, the benefit I think exceeds the risk. There is some risk potentially. So testosterone is not a cure-all for everything. Mm-hmm. And if the level's normal, there's really no evidence that it could help. And, testosterone given to people by either gel, injection, pellet, whatever, can have some side effects and negatives. And like it can increase the blood count, which could increase the thickness of your blood or viscosity, which could lead to stroke, things like that. It could overstimulate the prostate. That's another possibility. And I've had some people who are given testosterone who get very agitated, and that's not very often, but it happens. Mm-hmm. And then we back off or we stop it.
You handled it exactly the way my doctor did. So I was just interested
Excellent.
in your response. Yeah. And my levels didn't need addition, but I was in that mindset. I was like, how do I make sure that I'm stronger and fitter and have the best chance of staying alive as long as I can? Right. Okay. So I'm going to go to what I think is going to be a little bit of a long answer. So we'll finish with this one.
Okay.
This person says, I want to know the doctor's thoughts on microdosing GLPs.
Yeah.
Specifically for people with autoimmune disease and for people who do not need it to lose weight. My thoughts are that maybe a pharmaceutical version of these peptides is dosed far too high and too fast for type 1s. Maybe microdosing will negate many of the side effects, and maybe you'll get some of the inflammation, increased insulin sensitivity, and the other benefits that come along with it. I'm super interested in this because I just did an interview last week with CEOs from Xeris and Beta Bionics because they're working on a dual hormone pump. And I mean, honestly, what are we talking about there? We're talking about microdosing glucagon in an insulin pump. So,
right, exactly.
Yeah. So what do you think here about the idea of this possibility with GLPs?
The microdosing idea is a really interesting idea. And I'll go right out and say, I'm not sure exactly what that dose is, but I know that means less than normal. And I would think it might mean the same frequency or more frequent, lower dose, who knows. But microdosing, less than normal dosing, specifically for autoimmune diseases. And I'll say very quickly, no data. Would I do that for an autoimmune disease? Depends on which one you're talking about. Of course, some are more serious than others. The answer is for all of them, I guess. So it doesn't depend. The answer is no, I wouldn't do that. I don't know. I don't have data for that. And would I use it for people who don't need to lose weight? Well, that would be people who have diabetes who don't need to lose weight. And some people, because it does have an effect on glucose metabolism. So I would use the concept of microdosing is interesting. Data is not available. It's all going to be personal use. And we really need, I'm a scientist. We need a study to tell us what to do. Anecdote is going to get people in trouble. And the pharmaceutical dose could be dosed far too high. Maybe for certain things, but not for what we're looking at. They're dosed about right for blood sugar and weight loss and that. And then maybe people would have fewer side effects with microdosing. That's true. They also may have no effect. So we really have to have a clear-cut target, like use it in someone who has a particular type of autoimmune, a group of people who have a certain kind of autoimmune condition and have a placebo control and use a lower dose and find out. I don't think those studies are being done, but whoever wants to can suggest that to their people they know in the pharmaceutical industry. And would that increase some of the benefits like inflammation and sensitivity and things like that? I don't know, maybe. I think the current doses are pretty well worked out. These doses are taken from the bench to clinic, and all kinds of doses are looked at. You want a dose that actually has an effect. Right. And you need to have a target, like blood sugar or weight loss or something like that. Mm-hmm. And then you want to be sure that dose actually works. So I think the current doses are effective. The concept of exploring other areas is a great idea. And there are studies being done looking at like arthritis, like osteoarthritis, looking at sleep apnea. There's been some positive there already. That's about weight loss, I think.
Yeah.
And other conditions that maybe even some cognitive conditions like Alzheimer's. Could these meds help? People are looking at all kinds of things.
Mm-hmm.
But until we have a good study, I don't think I would jump in and start using it that way.
Yeah. Do you think you've seen anything, even just, N of one kind of like returns, where people have experienced less gambling habits, like other addictive natures? You've heard that talked about, but do you actually see it?
I have not had a person come back and tell me that they took it and they were not going to Las Vegas as often.
Mm-hmm.
Though
Gotcha.
I've read about that, and I think it's fascinating. Cravings, appetite is a type of craving. Gambling is a type of craving. Alcohol and alcoholism, I know for a fact some studies are going on looking at that. Do I know results? No.
Mm-hmm.
But I've had a few people come back and tell me they were less interested in drinking alcohol
How about that?
drinks. And there may be something there. If so, I sure hope there is, but I want to see a good study come back and tell me that actually was true.
Yeah.
And it may just be, it's not a consistent thing. I've asked some people, do you drink any less? And they say no.
Mm.
So we need something to tell us more about that.
I've noticed this thing. I'll end with this and ask you if you've seen it too. I think it's possible that as a society, we've become so used to people's body mass being larger that now I'm seeing people use these medications, get down to what looks like a very nice, healthy weight. And yet the people around them are shocked and say, like, my God, you're too thin, put weight back on, like, blah, blah, blah. And if you really look at them, like from a reasonable perspective, they're not too thin. They're not too anything. They just look like a healthy human being. It almost feels like that's not what people are accustomed to looking at, maybe with you personally or with people in general. But I was wondering if you've seen those kind of more psychological reactions.
Absolutely. That's true. Change is something that people notice and comment on. And historically, when people have lost weight, it's because they're sick and cancer or something like that. And I've certainly had people comment in that direction, or have people tell me they've been told they look sick, they need to eat.
Mm.
And their family, their friends, they say, here, you need to fatten yourself, eat and gain some weight back. Even though what you said is correct, their weight is now more normal than ever. I would tell people in the audience, expect that and understand it and take it as a compliment, and you'll let people know what you're doing. And if you want to,
don't let it thwart you. I've seen people, it happened to somebody around me recently. They were so pressured by the, oh my God, you're losing too much weight pressure, that they started thinking about not doing the medication. And I said, look, between you and me, I need to lose 15 pounds and maybe more. I don't know. Like, I have to tell you, like, my ability to understand how much weight I needed to lose is completely skewed, because I started this thing thinking 20 pounds, I'll be great. When I got to 20 pounds, I was like, I don't even look any different. And now if I said to somebody says, hey, you look great. I'm like, thanks. I still have 15, 20 pounds to lose. They go, that's not possible. And I'm like, well, I could take my shirt off and share it with you if you want. But like, I definitely still need to.
Yeah.
I just don't want people to get thrown off by knee-jerk reactions to their visual appearance. You know what I mean?
I agree.
Yeah.
The nice thing about it is people are concerned and they notice, and there is a compliment. It's people who are concerned. They think, oh, is there something going on? I care. I want to know. Or they may be just plain nosy. I don't know. But and you could reassure them and say, and now everybody knows about these meds, almost everybody. And you could divulge, or you don't have to. You don't want to maybe tell people what you're doing. You could say, no, I don't have cancer. I don't have some bad disease. I'm working on weight loss, and or something like that. But yeah, it's a common phenomena, and everybody should just expect it.
Yeah.
And it's actually a real big positive, but it comes off as you've lost too much weight. And of course the answer is no, you haven't.
Yeah. And by the way, I don't actually care about the number of my weight. I care about the fat my body's holding. That's what my concern is. So
exactly,
whatever I end up looking like after I'm carrying a healthy amount of fat on me is what I'm going to look like.
Right.
All right. Well, Dr. Blevins, again, this is terrific. I feel like I could just have a podcast where I chat with you about anything and it would be good. So thank you. I appreciate your time again.
Probably not. But no, Scott, thank you very much. It's fun.
Yeah.
I've enjoyed it.
Great. And we're going to have you back again. Is that right?
Yes.
Oh, excellent. Great. I'm super excited. Hold on one second. Jalen is an incredible example of what so many experience living with diabetes. You show up for yourself and others every day, never letting diabetes define you. And that is what the Medtronic Champion community is all about. Each of us is strong, and together we're even stronger. To hear more stories from the Medtronic Champion community or to share your own story, visit medtronicdiabetes.com/juicebox and look out online for the hashtag Medtronic Champion. Having an easy-to-use and accurate blood glucose meter is just one click away. contournext.com/juicebox. That's right. Today's episode is sponsored by the Contour NextGen blood glucose meter. We're starting to get a nice grouping of GLP-focused episodes. There's a full list of them in the featured tab in the private Facebook group. Thank you so much for listening. I'll be back soon with another episode of the Juicebox Podcast. The episode you just heard was professionally edited by Wrong Way Recording. WrongWayRecording.com.